So I hope to bring to this group, and I'm listing my disclosures here, that number one, I'm a primary care doctor by practice and training. So what I'm going to bring is the perspective of what happens to the people when they leave the operating room and end up back in the community trying to carry on their lives. And as a primary care doctor with that experience that Richard described, it is difficult. It is not easy to have chronic persistent pain. And this is chronic persistent pain that no one doubts is real or not, because we see from these remarkable images that there's a lot of structural abnormalities. And one of the important things that I want to stress in the course of this conversation is that there's a critical value to measuring what we're doing. And unlike the preceding conversations you've had, we don't have wonderful measurements in pain. We ask 0 to 10 how much it hurts, and then we typically stop asking that. And one of the concepts that I'll be describing in the objectives is realizing the value of measuring pain by more than one domain. Because when pain is acute and in the hospital, how much it hurts is obviously critical. It's the fifth vital sign. But once people have chronic persistent pain, the fifth vital sign becomes much less important. And we look for a lot of more complex measures that embed the individual in the real life that they're carrying on outside of the moments in the operating room, which are certainly hours, but in the patient's lives, it's a very short moment, and they have to reintegrate back into comfortable life. So I'm going to attempt to describe the different painful conditions. I'm going to move through them rather quickly, make a distinction between nociceptive and neuropathic pain, which is very important in our diagnostic and treatment considerations. Recognize again the value of measuring more than just pain intensity, and then run through very quickly, because it's a whole day's conference, about the different treatments that we might select. So as a general overview, and I'm going to just fly through this very quickly, the kinds of pain syndromes you've heard discussed already that we will typically see: headache, of course, a variety of facial pain syndromes, certainly neck pain. Looking at all that hardware that sits in the patient's neck after the fact, it makes me have a neck ache. Syringomyelia and the associated neuropathic pain states that are associated with that problem. And then an interesting newer concept of the importance of the descending inhibitory pathways in the modulation of that pain, and how important it is to recognize that, and helps us understand the different syndromes that are associated with the characteristic pain that may be seen in these individuals. And that includes a school of thought that I don't personally subscribe to, that fibromyalgia has been attributed by actually a local practitioner and some others as being a potential Chiari-like deformation, which I think doesn't have a strong evidence-based support. But what the basis of that is, because you may hear about that and how we might approach that from a clinical treatment perspective. And a condition called complex regional pain syndrome, which has a remarkably high incidence in this disorder, which sheds some light on the theoretical grounds as where CRPS actually may arise from, rather than the periphery, which has been one of the greatest challenges in pain medicine. It's a very, very difficult disorder to treat. Briefly, and you've heard already, the variety of spinal malformations and how they may affect the choice of treatments. And under Dr. Ellenbogen's team's care, I'm sure there are no complications of surgery. But when they do arise, acts of God, there are painful syndromes that may result in. And these are the spectrum of disorders that we in the pain field are confronting. A quick word about the descending inhibitory pathway, because this is going to set the theme. And I'm afraid I have no cool images. I'm going to have diagrams and cartoons, so nothing beats MRIs. It's a tough act to follow. But on the right side, you see the red line that ascends up on the left that describes the pain pathways. There's an injury to tissue, an injury to a nervous structure that transmits pain up to the brain. It follows the red. And all the different colored lines that are going down describe an extremely important component of chronic pain, and that's the descending pathways. Because the body naturally has to have a balance between what goes up and what comes down. We see this in coagulation disorders. There's procoagulants and there's anticoagulants. We see it in a variety of inflammatory pathways. And similarly, the nervous system needs to modulate or determine how important, how significant this sensory input is, and downregulate. A simple example of a robust descending inhibitory pathway goes back evolutionarily. Our ancestors on the eastern savannas of Africa are escaping saber-toothed tiger, and they sprain their ankle. They have two choices. They can stop and nurse their ankle and be overcome by pain, or they can continue to flee and not have any experience of pain. and obviously our descendants who made it by Darwin's principle escaped and fled. Otherwise, they were consumed by the tiger. And therefore, there's a genetic and evolutionary basis for a robust turn-off mechanism that modulates our pain experience. The medications that are most effective for management of neuropathic and chronic pain syndromes are currently deployed against the reduction in effectiveness of the descending neuropathic pain syndromes, the DNIC as we call it, and are designed to increase the ability to respond and basically turn off the ability of pain to get up into the central nervous system. And this is very important when I'm going to speak a little bit about tricyclic antidepressant drugs, which are, in my view, the mainstay and principal therapy that we have currently. And unfortunately, we have limited ability to treat some of these pain syndromes as effectively as we'd wish. As you've heard already, there's a variety of compressive syndromes associated with Chiari, both at the level of compression and then interference, because one of the key areas, if I just back up a minute, is this periaqueductal gray and then the medulla, which is often involved in the anatomic pathology associated with pain. And therefore, we will have problems both with the ascending pain pathways and the descending pain pathways. And what's interesting also, as I alluded to, there's a significant incidence of CRPS, much higher than expected, with a p-value of 0 because of the frequency of this in this syndrome. FM refers to fibromyalgia syndrome. Patients will have widespread, unexplained pain without tissue injury, as if the tissues are injured. That is heavily described now as a disorder of descending noxious inhibitory control mechanisms. TMJ, not just because the operation's near the joint, but because TMJ also has a significant requirement for a robust descending pathway. And chronic low back pain, for reasons that we saw, the tethering and the lower spinal pathology on a neuroanatomic basis. But we also know that persistence of back pain after a minor sprain also heavily depends on how robust the descending inhibitory pathways may be in the management of that pain syndrome. The number of locations in pain are extraordinarily wide in both frequency in terms of percent, but also in distribution. A small number actually in the genital, but a significant amount of pain actually well below where you'd even expect to see the pain, suggesting that the linear connection between this nerve is going to cause this pain has become disrupted by the pain syndromes. Muhammad Yunus is actually a rheumatologist, and in the early 90s, he began to recognize that there's a whole spectrum of what he calls central sensitization syndromes. I call this the pinwheel of events. Here's fibromyalgia, post-traumatic stress, interstitial cystitis, irritable bowel syndrome, headache disorder, TMJ disorder, and actually multiple chemical sensitivity disorders, where non-noxious stimuli, in other words, stimuli that should not be perceived as painful or distressing, and I would go chemical sensitivity even as an olfactory sensation, are experienced by these individuals as noxious, as unpleasant. So an example would be a fibromyalgia patient who you just press on areas of muscle and soft tissue that shouldn't hurt, report intense pain. And the most effective therapies that we have at this point for management of fibromyalgia syndromes, and in fact, the whole pinwheel here of described syndrome, turn out to be drugs that affect and are directly focused on targeting the descending pathways. And if the Chiari malformation is at the brainstem and affecting those structures primarily based on chronicity and postoperative consequences, it's not at all surprising that we're going to see a whole host of additional chronic pain disorders associated with these patients, accounting for the earlier representation that I described. Okay, pain management is very complicated. We have historically evaluated pain, as I indicated, by the fifth vital sign, the pain intensity, the visual analog score, the numeric rating score. And that was introduced quite appropriately 15 years ago when the Joint Commission basically dinged hospitals if they were not evaluating, in addition to blood pressure, pulse, temperature, and respiratory rate, the intensity of pain. And that's very relevant for acute pain. And on the acute perioperative team, postoperative Chiari patient surgery, it's highly appropriate that we're going to focus on pain intensity because that we can actually have a big effect on. And actually opioids are very effective at managing acute postoperative pain, particularly nociceptive, meaning it's coming in from our pain sensation system as a result of direct traumatic event. In the chronic pain field, instead of achieving pain relief, which is the goal of acute pain management, in chronic pain, our goal is improving physical function. So the goals are very different, and when we target in the pain center, it's less about pain intensity, and of course that's important, and it's more about function. Physical functioning and emotional functioning. And there's certainly no doubt that chronic, persistent pain, for young people, children, in fact, that we heard about, it isn't easy going through what these people are going. And as an adult, it isn't easy. And one's life becomes disturbed and disrupted, relationships with others, people become socially isolated, career and other life goals are turned on their head. So it's extremely prevalent that people have significant distress, and we interpret that as clinicians as anxiety, depression, and frankly, post-traumatic stress disorders that would not be surprising in young people who have to go through these very, very severe life experiences. And in the world of pain, it turns out that the most important measure of success is a patient's self-rated global improvement. The original multidisciplinary pain clinic in the world, when pain was identified as a disease unto itself rather than a symptom of another disease, that was actually identified here at the University of Washington by John Bonica and his team back in the 80s, really became an international center. In fact, the International Association for Study of Pain is located here in Seattle. Its first meeting was in Issaquah at what was then a nunnery, and the history of identifying pain as a disease unto itself was first recognized here. And at the original pain centers, when we would look at the outcomes of our patients, pain intensity may reduce 10%, but global sense of improvement would improve by 90%. Mood typically improved by 60%, and functioning about 30%. This is the summary data, and that became the gold standard. So if we're looking at what our desired outcome is, that the patient-centered care, goal-directed treatments that individuals want to have back in their life despite these terrible pain syndromes and the surgery and the resulting limitations from that, that they themselves feel that they are globally improved. So it becomes a lot less imaging and glamorous in terms of presenting it, and it becomes much more the patient's story and the patient's self-report. We also find it very important to evaluate the symptoms of pain, of course, on various organ sites and any adverse effects of our treatment, because there's really no drug we give that doesn't have a potential adverse effect. And certainly many of the drugs we use for pain lead to annoying things like constipation and dry mouth, to far more serious things like opiate overdoses and impairment in function due to overdosing patients on a variety of potentially ineffective medications. And then very importantly is disposition. In other words, how is the patient doing out of our direct office contact? What's going on in their life in terms of compliance with therapy? Are they seeing the psychotherapist for cognitive behavioral therapy like we asked? Are they attending the physical therapy sessions? Are they taking their oxycodone as directed, or are they crushing it and burning it and smoking it and selling it, which are significant problems and are contributing to the management of pain in all domains. And I must say that every patient that I've seen so far with Chiari, there's been none of this behavior in that patient population, but it has not been systematically studied. But the incidence of misbehavior and substance use problems in the chronic pain population is between 20 and 30%. So if the providers are leery about prescribing opiates in particular, they have good cause, because this is a very significant risk associated with this unique category of treatment. I've never had anyone abuse their insulin or their blood pressure medicines or their statins in my career as an internist, and it's shockingly and dismayingly prevalent in this population. Nicholson and Pasek from Utah in 2007 identified the 4 A's. So you're a clinician, if you're a patient or you clinicians listening, this would be a reasonable model, and is currently we consider best practice care. We evaluate the 4 A's. And the 4 A's are, one, is the drug we're giving effective? So there's no point giving a treatment when there's no result. Giving penicillin for a disease, infectious disease that is resistant to penicillin, it certainly makes no sense to continue treatment when it's ineffective. The second A is what are the effect of our treatment on our activities of daily living? And that includes physical functioning as well as emotional functioning. What are the adverse effects of our treatments? So it's extremely important that we know the details about side effects so that we can modify our treatment and address those adverse effects, because sometimes the adverse effects are considered by patients to be inevitable, and therefore they're just going to bear with it, when in fact many times we can adjust the medications and make very simple changes, sometimes even antidotes to those side effects if they're truly necessary. And of course, as I indicated before, the concern about aberrant behaviors. And I just rushed back, and I know I gave people pause when I came because I was almost late for the talk here, but I was speaking to medical students, and this is actually a requirement. They have to evaluate every patient every time for these 4As, or they go back in the room and learn it again as a measure of care. So as clinicians, I think we need to pay attention to it. If you're a potential patient here, if the doctor's asking about aberrant behaviors, it's only because there's a couple of bad apples out there that have required us to pay attention to these. So how do we monitor this? People say, well, how do you do all that? What kind of complex tools do we do to measure? Washington State, there's new legislative guidelines that are actually frightening providers away from using opioids because it seems too complicated. Well, in fact, you need to identify pain and relief of pain and improvement in function. Those are the two key elements. Here's the two items. 0 to 10 scale, all you need is a pen and a piece of paper to administer the test. 0 to 10, how much does it hurt? 0 to 10, how much does pain interfere with your function? And it could be global function, it could be a function that an individual identifies themselves as very important. An 80-year-old patient may say they want to be able to lift their grandchild. A 30-year-old man may want to be able to mow his lawn. Certainly getting back to work is important. Unload and load dishwashers, walk dogs, those are the kind of functional interference items. And if we give a treatment and we don't see movement down on that 0 to 10 score, our treatment's ineffective. We will stop using that treatment. Simple measurement. Is it working or is it not? We have a more complex tool, and this is actually a proprietary tool that we're a beta site and consultants for. It's called CPAIN. And what we're actually doing right now, we're about to come out with version 2. This is a version 1 screenshot. And you can see what we're doing is tracking, and this is a patient who's done well. We can see that pain intensity is reduced. We see that pain relief from the medication is improved. Pain interference with quality of life is down. A disability index is down, and a variety of other functional goals. So we can actually have a longitudinal tracking of things other than how much does it hurt. Again, as I mentioned, if we can get pain down from a 10 to a 9 out of 10, that's all we're going to get typically in a chronic pain setting. And it's discouraging, and I really hope during my career here we will come to some new discoveries that can move the intensity down. It's not around the corner yet. So I mentioned nociceptive and neuropathic medication diagnoses. So once we identify what nociceptive pain, and I would say nociceptive pain is how much it hurts after those screws have been drilled into the base of your skull. There's clear nociceptive pain, and that's very different than neuropathic pain in terms of how we might approach it. Neuropathic pain refers either to direct trauma to the nerve, at this compression in the spine, or the tethering of the phylum and the nerve tension problems that occur in neuropathic pain. But sometimes in patients, after the injury is relieved, after the malformation has been corrected and there's plenty of space, healing has resolved, yet pain persists. And this is when pain is a disease, and very often it's based on changes that have occurred in the total neuroaxis, both at the periphery, in the upper spinal cord, and in the brain itself. And it's been widely distributed. A patient yesterday asked, she wanted to get one of those beam therapies to burn the pain center out of her brain so she wouldn't have pain anymore. And she said, isn't there just one little spot you could cook and rid me of my pain? And unfortunately, despite early theories 30 years ago that it all resided in the thalamus and some other areas, it unfortunately is distributed throughout the entire brain, and we have no single area to burn. So we treat neuropathic pain quite differently. Here's the menu of pain treatments we might use for nociceptive pain. Acetaminophen, anti-inflammatories, corticosteroids if there's edema associated with. Opiates, extremely effective, of course, the management of acute, particularly nociceptive pain. And tricyclics and serotonin nonspecific reuptake inhibitors based on the predominance of norepinephrine that we're trying to raise, because that is the most robust element in the descending inhibitory pathway that we're now capable of monitoring. As far as neuropathic pain, you can see I've eliminated NSAIDs. They're ineffective and actually they're associated with the highest incidence of adverse effects, NSAIDs in the world and in the nation. They even exceed opiate adverse effects. Tricyclics and SNRIs, antiepileptics, and again, opiates do play a role in the management of neuropathic pain, despite theories otherwise. But the effect is not terribly robust. So if we look at just a moment on what neuropathic refers to, it's a recognition that there's a disorder of transmission and interpretation of the ascending components. We use the word wind-up and central sensitization that I described before. And here in the bottom left of the slide here, we can see there's a shifting of the pain intensity response to a particular stimulus to the left. And I would say, using, for example, oxygen dissociates from hemoglobin at a certain level, and it's left shifted, and people got to acclimate, and the body corrects when oxygen dissociates. The same pattern occurs in pain, where we left shift the curve, and here the dark blue line is the physiological pain component, and you can see that it takes a certain amount of sensory stimulus for the patient to have a painful response. People with persistent and central sensitization phenomena have a left shift where just touch, which is not nociceptive, it requires some stimulation of nociceptives, but it's not a noxious stimulus. Just light touch will produce what we call allodynia. So wind, clothing, blowing on people's flesh alone will produce terrible pain syndrome as a result of this left shift. And in pathological pain, the phenomenon of much more heightened pain and associated with what would be described as much less intensity, we call that hyperalgesia. And this is actually an old model that's been described, but still very relevant in our evaluation of neuropathic pain. So the problem with our medications is that, if you can see these average responses to pain, they're actually pretty pathetic. We get about, in chronic pain, this is chronic pain, not acute pain. In chronic pain, we get about a 30% average reduction in numeric rating, which is moving them from a patient from 10 to 7, or from 6 to 4. And we get all excited with that initial response, but upping the dose of the opioid beyond that dose we've chosen to get that 30% response has a temporary improvement in the patient's perception of pain, but that within 3 months it's back to the previous level and the person's on a higher dose opioid. And you keep chasing that dose of opioid higher and higher and higher, what you accomplish is an increased number of adverse effects without a sustained improvement in function. And that's what we see in the pain center, people with 10/10 pain on doses of opiates that exceed calculators, thousands and tens of thousands of milligrams of morphine equivalent, and yet they're still reporting 10/10 pain. And it's the phenomenon of less than, typically 50% would be a hallelujah moment if we get 50% reduction chronically, but 30% would be the average. Tricyclics and anti-epileptic drugs that we use had a similar response. Acupuncture, based on a few limited studies, improve your response to these other treatments by a further 10%. Cognitive behavioral therapy and psychodynamic, not psychotherapeutic, but psychodynamic behavioral connection to treatment of pain, actually you can see exceeds the benefits that we get with our medications. And interesting, physical fitness alone will raise those success rates quite substantially. And the challenge then is to be able to engage the patient in a fashion where they can tolerate a physical activation program. As an aside, this audience doesn't have time to ask questions, but I'm always asked, how about medical cannabis, medical marijuana, where does that fit? And the answer is it's about the same. Best studies show about 30% improvement in numeric rating intensity. And it's interesting, if you look at what physical fitness does, we all call it kicks up endorphins. Actually, some recent studies indicate that actually physical exercise increases endocannabinoids because people have the runner's high is not blocked with naloxone, the opiate mu receptor blocker. It's actually blocked with endocannabinoid blockers. So people who get the runner's high may indeed be getting a cannabinoid high. So where that fits in our pharmacological treatment spectrum remains certainly controversial. So using an integrated multidisciplinary rehabilitation incorporates all these domains. It deals with function, it deals with mood, it deals with assessment of quality of life. I'm not going to run through all these particular domains per se, but it's a restructuring and a problem-solving activity, and I describe it as if you might see a trainer. So I call these folks, even though they're PhD psychologists, cognitive behavioral trainers, because they train the brain and the descending pathways to behave more normally and more functionally and therefore people can become more engaged and successful in their life. Physical therapy and occupational therapy for functional restoration. And the key here is passive physical therapy does no good at all. Massage gives temporary relief. People have to stimulate the muscle, put normal pathways in place where you move, you use it, you keep active. And it's a challenge, and it requires a high degree of buy-in and motivation by the patient and a strong commitment of the physician and provider to maintain engagement, that it is worth doing because we see that physical activity is more effective than any drug that we have. The goal is to allow people to tolerate the physical activity, perhaps with some of these drugs, until they can get going, and certainly we look to reduce those drugs. You can see all my private life coming up here and my messages here. I'm going to get some Mariners, nice seats, by the way. That's a good message. Complementary and alternative medicine, hypnosis actually has been identified at increasing the descending inhibitory pathways. So there may be some advantage to hypnosis therapy as well. And acupuncture, as I alluded to, we're not sure how it works, but my guess is it's going to be a descending pathway stimulant as well, based on the kind of the complete cycle that we're learning. Sleep management. I've never met a chronic pain patient in their first visit who's sleeping. We know that you get up to, and actually at the university, at the sleep center, some preliminary data showing a 40% reduction in numeric rating intensity by just getting a good night's sleep. So that is your first target, and that's the first target that I go after when I treat my patients, because that's, I would consider, low-hanging fruit. The study was done on college students who had normal pathway response to pain, a variety of fancy testing. 5 hours or less of sleep, they were all wrecked. And those of us who've been on call all night, there's a number in the room here who've had this experience, everything hurts after that sleep deprivation. Yes?
My question is, aside for these folks, that's your first intervention, aside from normal sleep hygiene, what's your first medical choice?
Nortriptyline, tricyclic antidepressant drug. Good question. The question was, what would be the first drug of choice? I'm going to get to that in a moment, but it's spot on because the tricyclic antidepressants drug reduce pain, as well as any other drugs in neuropathic pain. Most of these people report significant distress. Many of them have scored positive on depression scores, so we're treating pain, mood, and sleep. You get all three, and you can manage that at low dose. I'm talking for the clinicians here, 10 milligrams. Nice thing about tricyclics, it's 10. You don't have to worry about alternative dosing. And you walk them up to 50. And if they're still not responding, that's certainly the time you talk to someone who has a little bit more specialty training in management of this type. Again, tricyclics, multi-purpose response, and we don't see significant dependencies. Sedative hypnotics are dangerous drugs in chronic pain. They increase adverse effects, falls, overdoses, and they develop chronic dependency. And interestingly, and importantly, the sleep drugs that are commonly prescribed, none of them maintain normal sleep architecture. So all the sedative hypnotics and the benzodiazepines that we use, if you look at sleep architecture patterns, REM is often just eliminated completely or shifted to the complete wrong part of the night. And interestingly, the only drugs that seem to maintain normal sleep architecture turn out tricyclic antidepressant drugs. They shift REM later. People have more vivid dreams because the REM comes later when they're about to awaken, so the dreams are often recalled. That's a common description, and people say they've got more vivid dreams. I say, yes, you're still REMing. I haven't knocked that out. Most people on other sleep drugs will have no recall of dream. And actually, benzodiazepines, when added to cognitive behavioral therapy, destroy the effect of CBT. For whatever reasons, multiple studies show that they're actually disruptive. Non-benzodiazepines may be useful, but again, short-term would be the goal. I've just spoken very briefly on it, just for the sake of time, discuss a little bit about the incidence of depression with chronic pain in general, and the challenge that we have as clinicians to be able to sort through this. Again, for the sake of time, the mechanism of antidepressant, I don't know if this shows up, but I'm just going to highlight all the pain pathways that tricyclic antidepressant drugs affect. They affect NMDA, they increase mu receptor avidity to mu opioids, they have significant norepinephrine reuptake, which is, we're targeting the descending inhibitory pathways. So there's a large scientific evidence, actually, Verdue in Drugs, 2008, actually one of the best review articles on the management of chronic pain using tricyclic antidepressant drugs, making a very strong case for that. So this is a quick question. Muscle relaxants. A, B, or C, they relax muscles, patients or doctors. Actually, the slide is wrong. Actually, the correct answer, this didn't translate correctly on the switch. Actually, the relaxed patients and doctors, they don't relax muscles. Chronic muscle relaxers do nothing for the management of muscle relaxation. In acute studies, they do have an improvement, but in chronic use, they relax the patient, i.e. they sedate them, and they relax the doctor because we can give them something and not feel bad about doing nothing. But chronic muscle relaxers, we take off all of our patients. They play no role in the management of chronic pain. We use antiepileptics frequently for neuropathic pain for a variety of sensible reasons that are outlined here in terms of reducing the discharge of transmission of typically ascending, but possibly also descending. And if we inhibit descending too much, we may lose the benefits of these drugs, hence their less robust effect. In terms of evidence-based studies on the role of antiepileptics in neuropathic pain states, you can see that the numbers needed to treat are only 1 out of 4. In the diabetic studies, there's been no studies in Chiari, and in fibromyalgia, the numbers needed to treat are again quite an unusual 1 out of 4 to 1 out of 9 or 10. So they're not nearly as effective as the tricyclics, which have numbers needed to treat about 1 out of 2 on the same comparative fibromyalgia studies and the diabetic peripheral neuropathies. So rather than reaching for gabapentin or pregabalin Lyrica, I would reach for nortriptyline, amitriptyline, or doxepin as my drug of choice. The side effects of the gabapentinoids are significant, and if the numbers needed to harm are about 6 to 14, we're going to run into actually a toxicity and adverse side effect rate. We use a lot of other antiepileptics listed here. These are more complicated, and unless you have specific expertise in management antiepileptics, I know certainly neurologists will, Dr. Lucas and others know how to manage these, but they are tricky and are associated with a variety of metabolic issues and have multiple drug interactions with many of our other treatments. So again, some specialty expertise is very useful. The American Pain Society and the American Academy of Pain Management and Medicine again identified that opioids alone are never to be done because they're associated with multiple complicated side effects and poor treatment outcomes. And coming from a pain clinic, it would behoove me also to speak about some of the interventional strategies that are often used. Interventional strategies are excellent at precise diagnosis of where the nerve injury may be. They may allow us to provide specific selective nerve destructive procedures to disrupt the innervation. But when pain is chronic, it becomes more of a problem because many of these procedures are short-term, and we're talking about the life of the patient. So we use spasticity management, baclofen, intrathecal pumps, and sometimes opioid pumps to deliver opioids at a ratio of about 100 to 1, the ability to elevate this opioid effectiveness if you deliver it correctly to the spine. And in areas of specific neuropathic pain, we can provide a stimulator which puts an electrical current through the spinal column and replaces pain with another sensation. We're converting a noxious sensation of pain down the leg or pain into the arm into a buzzing, burning, water flowing sensation, which patients will much prefer than the intense, noxious experience of pain. It does not take away pain, it just switches it. It's like white noise for someone who's got tinnitus. It just substitutes one sound for another. So in conclusion, Chiari is certainly associated with many kinds of chronic pain for a variety of reasons. Multidimensional assessment is critical, particularly in the management of chronic pain, because in the chronic pain states, the ability to just drop the numeric rating intensity of pain is unfortunately and sadly limited based on our current pharmacopoeia and our treatment menus. There are many drugs on the positive side and non-drug treatments that are available and effective, and that we still need, and sadly still need, and I wish I'd be a much happier clinician, as would be my patients, even more effective treatments, and we are certainly working on them here at the university in the research part of the Division of Pain Medicine. So thanks for your attention and your time. I hope I didn't run too over time.